Evening, and welcome to tonight's webinar. We are excited to welcome Dr. Susie Bergman, an orofacial pain expert who will host an informational panel exploring common signs and symptoms associated with trigeminal mediated pain, helping you to identify this type of pain and facilitate early detection and appropriate referrals. You will also hear about the paths followed by 3 people with facial pain in their own words and learn about their experiences, providing insights on what they felt, which medical professionals they saw first, and what advice they have for dental professionals. Before I introduce Dr. Susie, I'd like to cover a few housekeeping items. First, there's a Q&A button in the toolbar at the bottom of your screen. Please use that to submit questions. There will be time to answer those after Dr. Susie's presentation. Also, there is CE credit available for this session. We'll provide the code you'll need verbally and in the chat after the presentation. In order for you to get your CE at the end of the course, just go to cezoom.com, log in, scroll down until you see scheduled courses in your account, click the green Verify button for this course, enter the verification code given, and take the mandatory course evaluation and any tests. And for those of you who are not already CEZoom members, you will need to create a free CEZoom account to get your CE. There, you can download your certificate or decide to keep your CE stored digitally inside the CEZoom platform. Now let's get to our presenter. Dr. Susie is a researcher and devoted dental practitioner, passionate about improving healthcare outcomes for patients. Since graduating from West Virginia University, my alma mater, in 1994, she has been involved in clinical care, postdoctoral education, research, advocacy, and infrastructure for patients suffering from orofacial pain. Dr. Susie is a selection chairperson, advisor, honorary program faculty member, and fellow of the TMJ Foundation's online fellowship program, FTMJF. She lectures internationally as a tenured instructor for McGann Postgraduate School of Dentistry and Progressive Orthodontic Seminars. Dr. Susie is a visiting scholar at Oregon Health Science University in the Department of Neurosurgery, where she is a co-investigator in research surrounding the differential diagnosis of trigeminal neuralgia and TMDs. Dr. Susie recently delivered a TEDx talk entitled, "Why is Healthcare Disjointed?" We'll share the link at the end of this presentation. Welcome, Dr. Susie. Please go ahead.
Thank you, Brandy, for that wonderful introduction. And it's so nice to have a fellow mountaineer to share this presentation tonight. So I just want to thank everyone for coming. I'm going to share my screen. And we are going to talk about what trigeminal mediated pain looks and feels like. So to give a little bit of context, the reason that this topic is interesting to me is because I am a patient who suffers from facial pain and have for about 35 years. And so I feel very attached to what I'm talking about, even from a personal angle and as a provider. And I want to start out by just talking about the definition of pain. So in 2020, the IASP changed the definition of pain to what it is today: an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. What's important for us to understand is that pain is a personal experience, and it's influenced by varying degrees to varying degrees by biological, psychological, and social factors. So through a person's lived experience, they learn the concept of pain, and a patient's report of pain should always be respected. Another thing that's important to remember is that a verbal description is only one of several behaviors that someone will use to express pain. So inability to communicate doesn't negate the possibility that a human being is experiencing pain. One of my mentors is Dr. Jeff Okeson. He is considered by many to be the father of orofacial pain in dentistry. And I have this picture here because it reminds me of an analogy that he gave. He said that there is an ocean of information out there about pain, and we're sitting in a small rowboat looking down in the water around us, recognizing things that we see and attempt to understand. But when we turn our heads up and view the entire ocean of information, we need to be humbled by so much that we have yet to appreciate and understand. And we need to acknowledge this concept so that we don't manage our patients with unnecessary treatments associated with the narrow information that we think we know about brain function. So I'd like to quickly just review for those of us who are providers what the trigeminal nerve is. It's the fifth cranial nerve, and it is the largest cranial nerve, which is responsible for providing sensory information and motor impulses to the face and neck. It has three branches, and those of us who talk about the trigeminal nerve often do this to show where the three branches are. The first branch, commonly referred to as the ophthalmic or V1, supplies sensations to the forehead, the scalp, and the front of the head. V2 supplies sensation to the cheek, the upper jaw, the upper lip, teeth, gums, and side of the nose. And then V3 supplies sensation to the lower jaw, the lower teeth, gums, and the lower lip. It also provides motor impulses to the muscles of mastication, which are responsible for chewing, biting, and swallowing. And we'll talk about this a little bit more in a moment. But next, I want to talk about neuropathic pain. What is neuropathic pain? This is a chronic pain that occurs when the nervous system malfunctions or gets damaged. An important distinction needs to be made between protective pain and pain as a disease. So protective pain examples would be things like nociceptive pain or pain caused by an injury to the skin, muscles, or soft tissues, like when you touch a hot stove, or inflammatory pain, which is caused by tissue damage or infection. This type of pain helps heal the body, but chronic pain is considered a disease in its own right, not just a symptom. Chronic pain can be harmful to a person's well-being, their quality of life, their productivity, and their functionality. And trigeminal neuropathic pain has the following signs and symptoms: numbness, sensory disturbances, and motor weakness. So again, a definition is helpful, and there is a new definition for neuropathic pain that just says it is pain caused by a lesion or disease of the somatosensory system. The old definition was criticized for using the word dysfunction because that term was thought to be over-inclusive and didn't really reflect the pathophysiology. It's also important for us to understand that neuropathic pain isn't just one disease entity, but a number of diseases or lesions with a cluster of signs and symptoms. And the understanding of the pathophysiology is still evolving. So another thing that's important for us to recognize about neuropathic pain is that when we're talking about the trigeminal nerve, the the term neuropathic pain is an umbrella term for a few different disorders. One of those would be trigeminal neuropathic pain from the herpes zoster infection. And this is 5 times more common in V1 than in V2. Most of the attacks are on one side only, and it's very important that this be detected and treated early, because if it's not, it can lead to permanent disfigurement and even vision loss. Another type of neuropathic pain in the trigeminal nerve is post-traumatic trigeminal neuropathic pain, which is a mouthful, so we call it PTTN. And this is a chronic pain that lasts for over 3 months and occurs after an injury, like trauma to the face or an extraction of a tooth or certain surgeries, which actually is something that I've experienced myself, and it's very unpleasant. This type of pain can be relieved by peripheral nerve stimulation, and that is very helpful in getting the pins and needles feeling to go away. Another type of pain is trigeminal post-herpetic neuralgia. And this is when the herpes zoster infection leads to months and years of persistent pain, even after the rash has gone away. And this can severely impact the function and quality of life for a patient. Now, when we talk about cutaneous or skin symptoms of trigeminal neuropathy, we need to understand that this is usually numbness, either partial or full numbness, but it can also be what we call hyperesthesia, which is a discomfort. It's a burning, itching, sometimes actual a description of pain that's perceived along with some loss of sensation. So a little numb, a little like that feeling that you get when anesthetic is wearing off after a dental procedure. Some more symptoms are visual symptoms, especially when V1 is involved. And like I said, if it's not treated right away, it could lead to vision loss. Motor manifestations are present, like muscle spasms in the muscles of mastication, especially the masseter muscles, or weakness or trismus can be present. We need to look for tone in the temporalis muscle and strength in the masseter muscle, because if we have weakness in those muscles, it can cause difficulty with things like eating, drinking, and speaking. And then sometimes there will be a hyperreflexive jaw reflex. So we can see motor manifestations like clonus in patients who have trigeminal neuropathy. And then painful trigeminal neuropathy is a continuous pain where the patient will say, oh, you know, this hurts even to the lightest touch, or things that are cold feel extremely cold to me. Now, the pathophysiology or the functional characteristics that we're looking at depend on the cause. So trauma during a dental procedure can often damage the inferior alveolar nerve and the lingual nerve. A neoplastic process, so a type of tumor cancerous lesion, can spread in the nasopharynx. It can be in the maxillary sinus, the trigeminal ganglion itself, or even other cranial nerves. And systemic inflammatory diseases like Sjogren's syndrome, scleroderma, or other connective tissue disorders can result in deposits of immunoglobulin along the nerve, or proteins in the cerebrospinal fluid vasculitis, and other autoimmune processes. The pathophysiology we need to understand is varied and depends on the etiology. If we consider someone who has purely sensory involvement, then we really need to consider connective tissue disorders in our differential diagnosis. Now we're going to talk a little bit about trigeminal neuralgia, which is one of the more well-known problems with trigeminally mediated issues in the nervous system. And trigeminal neuralgia is a chronic pain disorder that causes sudden severe facial pain. And anyone who has trigeminal neuralgia can tell you the day they got their first incident of it. I have seen this clinically over and over. A patient will come in and they'll say, on January 14th, I was taking a shower and I felt this sharp pain next to my nose, and it was the most painful thing I had ever felt in my life. Some of the characteristics that patients will describe are things like it will be on one side of the face, it's stabbing, it's burning, it comes on very suddenly, and it has a trigger. And so rather than go into my description, I would like to let you watch a short video that was made by the Association of Migraine Disorders. And this is a very good explanation about trigeminal neuralgia. And I love this website for their explainer videos for other types of headaches. So if you haven't checked it out, I highly recommend it.
Trigeminal neuralgia is a neurological condition that causes severe electric shock-like shooting or stabbing facial pain, typically on one side. Trigeminal refers to the trigeminal nerve, and neuralgia means nerve pathway pain. The trigeminal nerve is the largest of 12 cranial nerves originating deep in the base of the brain. It contains 3 branches that relay sensations between the brain and the face. It is also responsible for some of the motor functions of the face, mainly chewing. Trigeminal neuralgia can be classified as classical, secondary, or idiopathic. Classical trigeminal neuralgia is caused by compression of the trigeminal nerve by a neighboring blood vessel. Secondary trigeminal neuralgia is caused by compression of the nerve by an underlying disease such as multiple sclerosis, a tumor, or vascular malformation in the skull. Idiopathic trigeminal neuralgia occurs when a specific cause is not found on neuroimaging or other testing. In between attacks, the pain can be continuous, near continuous, or absent. For some, trigeminal neuralgia pain is not triggered by anything, but for others, activities like shaving, eating, wind exposure, applying makeup, or any other movement that touches the face may trigger pain. Trigeminal neuralgia is often diagnosed after exclusion of other disorders such as cluster headache, post-shingles nerve pain, or temporomandibular disorders. An MRI is typically used to confirm the diagnosis. First-line treatment should be carbamazepine, an anti-seizure medication. If necessary, other anti-seizure medications as well as muscle relaxers and various nerve pain medications may be used as off-label treatments. A neurosurgeon is often consulted to explain the various surgical options available. One surgery commonly performed is a microvascular decompression, which separates the trigeminal nerve from the compressing blood vessel. Due to the severe pain and disability experienced with this condition, a person should seek an experienced clinician to learn about the different medical and surgical options for trigeminal neuralgia.
So like I said, I really like these explainer videos, and I recommend, oh, sorry. I didn't mean to stop sharing my screen. 1 second. Okay. I highly recommend these videos because they're easy to understand. Now, let's see. I'm just having a little trouble getting to the next slide. 1 second. There we go. Okay, so very quickly, because I'm already going to run over just slightly, but I want to talk about another type of trigeminally mediated pain, and that is trigeminal autonomic cephalgias, which are called TACs. They're rare, short-lasting, disabling primary headaches, such as cluster headache, paroxysmal hemicrania, hemicrania continua, or Sanctum suna. And these are very, very rare. Although cluster headaches are something that people do know a little bit more about. And these usually happen as intense headaches on one side of the head, and often they can last anywhere from 15 to 180 minutes, and the patient can have 1 to 8 episodes daily. And they're very, very agitated when they're having these types of headaches. Now, it's important for us as practitioners to do a differential diagnosis where we're thinking about whether something is likely or if it's just something that may need to be ruled out, or if it's not really likely at all. But in our differential diagnosis, we need to remember that trigeminal neuropathy is constant. It's unilateral pain. It doesn't have a trigger, and it's unremitting. That is very different from TN, which is not constant. It's paroxysmal, it's unilateral, and it has triggers. And these pains last from seconds to minutes, but they don't last for hours. They may happen over and over again, but they go from 0 to 60 and back down. Cluster headaches have a sudden onset of pain, and it's generally around or behind the eye, and the pain builds up to a peak. And like I said, restlessness can be present. Another thing that is a syndrome of the trigeminal nerve is called first bite syndrome. When someone has a type of surgery like temporomandibular joint replacement surgery, they may have a period of time where every time they take their first bite of a meal, it is excruciatingly painful, but then the pain starts to lessen with each subsequent bite. And then dental pain, which we're all familiar with, unfortunately, almost all of us are, is a dull, continuous throbbing pain that's triggered by something being done inside the mouth. Now, to diagnose for trigeminal neuropathy, we need blood work, like a rheumatologic panel, and a radiological assessment. For TN, the history is the most important. The patient can tell you that they have TN just by describing what's going on with them. And often an MRI is ordered to see if there is compression on the nerve by a vessel. And then for the trigeminal autonomic cephalgias, a neurological exam needs to be done, along with taking a patient history and possibly having the patient keep a headache diary and let us know how they're responding to medications. For trigeminal neuropathies, we typically go with pharmacological treatments, and I'm going a little bit fast here just to get through all of this. We already heard on the video about how TN is most often managed. And then for the trigeminal autonomic cephalgias, we use corticosteroids or long-term preventive medications, indomethacin, sumatriptan, or anticonvulsants. Now, if we have a response to indomethacin, that tells us that it is probably hemicrania continua, because that is the one that responds well to indomethacin. Now, just to finish up, I want to tell you a really quick story about a patient that I saw in the neurosurgery clinic who came in complaining of pain in his face, and he had been told that he had trigeminal neuralgia. But the patient didn't have an interpreter, and English wasn't his first language, and the patient was pointing to his face. And the neurologist just immediately thought, oh, sharp pain in the face. This is trigeminal neuralgia. When I had the patient open his mouth for me, I discovered that his severe pain was coming from an ill-fitting denture. And so it's important for us as clinicians to remember that we need to look at the whole person. We need to ask the right questions, and we need to not just assume that something is what we're most familiar with. So that's where I would like to end my talk today. I want to thank all of you for joining me, and I want you to remember that the doctor and the patient need to make a team. And with that, I am going to introduce to you some of our patients who are here to share their personal stories. I'm going to start with Anne, who is a retired senior fellow from Mathematica, where she specialized in health and economic policy. Her mother and grandmother had trigeminal neuralgia. Anne has seen treatment evolve from the ineffective alcohol injections her grandmother used to the high-tech MRIs, MVDs, and gamma knife that alleviated her pain. She serves on the New Jersey Commission on National and Community Service and the Women's Space Advisory Council. She's a domestic violence victim advocate and therapy dog handler. Anne lives in East Windsor, New Jersey, and with her husband, John. They have 2 sons and 3 delightful grandchildren. Anne also serves as the Facial Pain Association's board secretary and is co-editor of the Facial Pain, a 21st Century Guide. Over to you, Anne.
Thank you very much. I'm going to share my story with you in 3 chapters. So it's 1965. Lyndon Johnson just sent troops to Vietnam, and the Beatles dominated the pop music genre. I was 13 years old. Cars were big, and I was sitting in the back of my family's bright white Chevrolet Impala. It had red interiors and fins large enough to land a jet plane. The night was bitterly cold. It was the second night in just a few that my mother had a tooth extracted. She went to the dentist with pain a few days earlier. He extracted a tooth then too, but her pain did not subside. He continued to pull another, assuming that he had taken the wrong tooth or there were 2 teeth with problems. Does anyone know the Shel Silverstein poem, Crocodile's Toothache? That's what it felt like. After a short drive home, my mother, with her head wrapped in a kerchief because cold air bothered her, began to cry. It was at that very moment that she realized she did not have a toothache. Like her mother, my grandmother, she had trigeminal neuralgia. And since I have only 5 minutes, we're going to fast forward 30 years. And it's 1998. Bill Clinton was inaugurated in January. And the first murder trial, that of the Menendez brothers, was televised. We were dancing to the rhythm of the night. At 42 years old, instead of being a young teenager, I was the mother of one. I went to the dentist with tooth pain, and the dentist said I had an infected root, and he performed a root canal. After a few days, then 2 weeks, and even a month, I felt no relief. The dentist checked and checked again and said the root canal was perfect. His friends, the oral surgeon and the endodontist, agreed, and the endodontist added that I needed an apicoectomy. I saw more dentists, including an oral facial pain specialist, and no one seemed to know what to do. 11 years later, I was on a business trip to Los Angeles and found my way to Dr. Stephen Graff Radford. I recognized his name from the dental literature. I was in his office for all of 10 minutes when he declared, "I know what you have and I know how to fix it. You have an unusual presentation of trigeminal neuralgia." An MRI confirmed that there was a blood vessel pulsating and impinging on the trigeminal nerve. And after an MVD, I had no pain and no drugs for 5 years. I had another MVD 8 years later and a gamma knife. And now I'm left with some neuropathic pain, which at its best is annoying and at its worst feels like a pizza burn. Now think about this. It took 11 years to get a diagnosis. 11 years. And no one made, except Dr. Graff Radford, made the connection with my family history and my pain. It was a very difficult 11 years for me. Now I want to wrap up my story by moving into the present. Because dental professionals like you are in this virtual space, we're hoping that people who present with trigeminal neuropathic pain will be assessed for trigeminal neuralgia before invasive work is done. Getting accurate and faster diagnoses tames the beast that is trigeminal neuralgia. And as a patient, I thank you for being here. I have a little bit of advice. People are going to come to you with pain and they're going to beg you to do something. And if you don't do something, they're going to go find somebody else who will. This is very difficult for you and very difficult for the patient. But you could use the FPA to help you. The FPA has a wonderful website and a beautiful guide called the New Patient, a beautiful handout called the New Patient Guide. And you can get as many copies of this guide as you want for free. Just call the FPA or download it from the website and hand it to the patient, because then you'll have something immediate and tangible to give them that will explain the importance of waiting. It's really hard to wait when you're in pain. And I don't even want to think about what I promised those dentists if they would just fix my pain. So please, please keep copies in your office and depend on the FPA to help you through this. And if you're really brave, you might give your patients a starting dose of an anti-seizure drug rather than an opiate. Opiates won't help the trigeminal pain, and a positive reaction to an anti-seizure drug is diagnostic. So thank you for listening to my story and for helping patients get faster and more accurate diagnoses so they can live their lives with little or no pain. And it took everything in me not to read The Crocodile's Toothache tonight.
Thank you so much, Anne. That was wonderful. And I would like to introduce our next panelist, who is Anne Marie Clark. Anne Marie is a retired family court judge. She and her husband, Richard, live in St. Louis, Missouri. She loves to travel and is grateful for the help she has found for dealing with trigeminal neuralgia through Facebook and support groups. She's most thankful for her dentist, who didn't treat the pain as a dental problem, for the endodontist who realized the pain didn't require a root canal, for her primary care physician who was familiar with TN and made the referral to the neurologist, and to the neurologist who listened patiently throughout this journey and made the referral to the clinical trial, which found a medication that has been most helpful in managing her TN. Anne Marie is also a member of the Facial Pain Association's Board of Directors. Welcome, Anne.
Thank you, Anne Marie. Thank you.
Anne Marie, sorry.
We have an Anne Marie. Yeah. My TN journey began, as said, being able to say when and where. But December the 5th, 2018, I was brushing my teeth. My husband and I were getting ready for a trip to Jamaica to celebrate a friend's birthday. It was a sharp pain to the upper left tooth, to the upper left tooth. I had naproxen from a prior dental appointment and was using that. Took the bottle of medication with me on that trip. I was in pain constantly. It was a sharp shooting pain. It was not like a dental pain, but it was more excruciating than anything that I had imagined. I returned from Jamaica on December the 9th, and was able to see my dentist on December the 10th. He took x-rays and said that he thought it might be probitis. He didn't know what that was. But he did make a referral and sent me to the endodontist. The dentist also thought it might be a dead nerve, and the reason also for the referral to the referral about the root canal. I saw the endodontist on December the 19th. His words were, there's good news and bad news. The good news is you don't need a root canal. The bad news is you don't need a root canal. And he then referred me to an oral surgeon and a neurologist, but I would not have been able to see either of those until sometime in April. And I was in constant pain. One thing I did realize is, for me, talking seemed to exacerbate the pain. And as a judge in a family court, I had to talk on a regular basis. What I found I was able to do is simply stop talking, kind of just clench my jaw. And as people in my courtroom thought, Judge Clark is being reflective and gathering her thoughts, but it was to try and just let this pain pass. I did see my primary care physician on December the 27th, 2018, and she made the referral for the MRI and to a neurologist. And it was on January the 7th that I saw, 2019, that I had the MRI, and then went back and saw my primary care physician. And this was the first time that I heard the word trigeminal neuralgia. She made the referral to me to a neurologist who is well-versed with TN here in St. Louis. And I was seen on December the 28th, 2019, and received my diagnosis. Thank you.
Dr. Susie, you're muted.
Sorry. Thank you so much, Anne Marie. And we have one more panelist who is going to share his story with us, and then we're going to have a time for questions and answers. So our last panelist is Bennett. And Bennett hails from Philadelphia, Pennsylvania, and has been living with trigeminal neuralgia for 9 years. Bennett is currently a second-year rabbinical student at the Jewish Theological Seminary. He also earned bachelor's degrees from both the Jewish Theological Seminary and Columbia University in Talmud and political science, respectively. After college, he spent 3 years working for a Jewish human rights nonprofit called TRUA. In December 2023, Bennett won the Young Patient Committee's Patients Committee's essay contest, and his essay was published in the Facial Pain Association Journal. Bennett lives with his husband, Isaac, in New York City. Welcome, Bennett.
Hi, thank you so much. Before I get started, I really want to thank everyone who's on this webinar. As will become clear from my story, I also first saw a dentist before being diagnosed with TN. And I feel extraordinarily lucky that my dentist fairly quickly figured out that he was not the correct person to be seeing me, and saved me a lot of potentially irreversible pain. So my story begins during my junior year of college, when I started to feel some sharp shocks in the bottom right of my jaw towards the end of midterms, which was a particularly stressful time. I came home and expected that the pain would ease as the stress dissipated, and it didn't. And so we went to my dentist, and he prescribed antibiotics. A few days into the antibiotics, there was no effect. And he immediately said, I think that you should see a neurologist. So we went to my PCP to get a recommendation. She gave me carbamazepine, and the rest is history. I feel like I can tell you the story of the flares that I've had and the intense pain that those came with. Or I can tell you the experience of being surprised when, after a long period of time, the pain comes back. Or I can talk to you about the fear of having big conversations like, is now the correct time to have surgery as a young patient, knowing that a surgery doesn't necessarily work forever. I don't think that's actually important. I think that the important part of my story and what I can offer is a little bit of an explanation of what TN does to a person, not just physically, but emotionally, socially, spiritually. I experience chronic pain. I experience TN in three big ways. During a flare, it inhibits my ability to talk without pain, to eat, and to brush my teeth, which fundamentally are the ways that I am social, the ways that I enjoy life, and the ways that I feel clean. And when those are inhibited or prevented, I start to spiral into a really bad mental health place. This has happened twice. I feel shut off from community. The last time that this happened, I was like not able to speak at all for a number of days. I usually return to my parents' house, which means that I'm physically apart from the communities that I'm a part of. I can no longer enjoy food, and I will sometimes go for days without brushing my teeth. That has an effect on someone on a social level, on an emotional level, because we are social creatures. And in lots of ways, communities and the communities that we are a part of are how we identify ourselves. And so when I have a TN flare, it isn't just that I experience the pain in the bottom right side of my face, it's that I experience a loss of identity from the people around me. It was mentioned, a fifth year rabbinical student, or second year rabbinical student at JTS. And I think a lot about how Jewish communities talk about pain and illness, and in the ways that pain and illness is talked about in broader society. And there is a convention both within secular society and within Judaism that a lot of our language about pain is temporary. People will say, I hope you get better. In Hebrew, there's a term, refuah shlema. You should have a complete recovery. People assume that people are sick and then they go to the doctor and they get medicine and then they're better. And for people who have TN, we know that that's not our reality. We're either going to be medicated and sometimes the pain will break through and we have to reorganize our medication, or we'll have a surgery and it will work or it won't work. And even if it does work, we'll still have this like sword of Damocles hanging over our head for the rest of our lives. And so we need new language in our communities, both socially, secularly, and religiously, to talk about the experience of people who have pain that isn't temporary. And I see that as a deep part of, an important part of my future in the rabbinate, and also my future in the various social communities that I'm a part of. When human beings identify themselves by communities, and communities want to express care for those individuals, the language that they use often reifies the sociology and the like philosophy and theology of a community. And so by continuing to say, I hope you get better soon, we actually continue to reinforce that that's a thing that happens. And I think it's really important for you as medical professionals and dentists to understand that when you give someone a diagnosis that this might be TN, that this isn't just, I think I can get you a medication that will help you now. It's a pathway towards a life of chronic pain that requires an entirely different vocabulary than is needed for someone who has a root canal and can get their tooth removed and then solve the problem. That's what I have to offer. I hope that that gives you a good picture of not just me, but also how I think about TN and the impact that it plays on my life. So I'll turn it back to you, Dr. Bergman.
Thank you so much, Bennett. That was very impactful. And I just appreciate all three of you for sharing your stories, for giving us a perspective, a way to think about these painful episodes that, like Bennett said, this is a new way of life, a new path, and we need to, as providers, understand this and be empathetic. When we cannot offer a cure, we need to offer consolation. And I really appreciate all three of you for sharing your stories with us. This is my contact information. If anyone would like to email me, you can call my office, just let them know that you're not selling something, or you can go check out my website. Here is something that I think people have been asking in the chat. The code for credit and instructions to access, so that you can get your CE. And I think I forgot to mention at the beginning of the talk that I had nothing to disclose, or maybe I did. But I am so glad to know the Facial Pain Association and the excellent work that's being done here. And now we have a few minutes for questions. I'm sorry that I ran over a little bit, but we do want to take your questions.
Thank you so much, Dr. Susie. Thank you, Anne Marie, and Bennett. It was incredibly impactful, your presentation, helping educate those who are with us this evening, and then being able to hear patient perspective and experience. There are several questions here in our Q&A, and I'd like to get right to them. So when someone is in the dental chair and they are experiencing what a dentist might think could potentially be either trigeminal neuralgia or trigeminal neuropathy or other trigeminal mediated pain, which specialist would you recommend they refer that patient to?
So I would typically start with a referral to a neurologist if there hasn't been a diagnosis yet. If someone already knows that they have trigeminal neuralgia and this is something that isn't being managed with medication, then sometimes we need to go to neurosurgery. But I actually, I volunteer in a neurosurgery clinic once a week. And we very often get patients who either haven't had their pain managed properly yet or haven't received the correct diagnosis. So I just want to stress that it's so important to get to the correct diagnosis so that we know the correct way forward for the patient.
May I add to that, please? Neurologists treat a lot of conditions, and trigeminal neuralgia is one of the rarer ones that comes into their office. And I would always want to look for an orofacial pain specialist. That's a new specialty in dentistry in the past couple of years, and you can find one on the AAOP.org website. So it's orofacial pain dentistry, and I'd look for someone who's a fellow of the that association. And
But can I add something to that? Not
Sure.
every state has an orofacial pain.
That's right. That's right.
So,
That's right.
so if you don't have one in your state, don't despair.
Mhm.
You know, orofacial pain is a brand new specialty in dentistry, and we only have about 20 states in the country that have orofacial pain specialists at this time.
Thank you, Dr. Bergman and Ann. Thank you both for commenting on that question and helping provide that answer. So we have another question here that is asking about genetic testing for patients specifically in Asia. But, I think we should take a step back there and talk just in general. Is there any current genetic testing that can be done that helps to diagnose or identify people with different types of facial pain?
Yes, genetic testing is actually a really hot topic in facial pain, orofacial pain, neurosurgery. There is a lot of work that's being done. The neurosurgeon that I work with at OHSU is actually involved in a really, really interesting study. And this is another one of those situations where we're really sitting in that little boat on the edge of the ocean. So there's some that we know. We do recognize some hormonal and genetic factors, but there's a lot that we're still learning. So it is it's an emerging and evolving field.
Thank you. I think that's something that, um, the Facial Pain Association also partners for research and advocacy. I think that's something that, hopefully as we learn more, we'll be able to share that information out with patients and with providers. Someone said, just kind of shared their personal experience that, in addition to being a dentist, they also live with trigeminal neuralgia. I won't share their name just for their privacy, but I think it's wonderful that we have so many providers who do understand what it's like to live with this chronic pain. And that's something, Susie, that I've, always admired about you is the, not only understanding as a provider, but also as someone living with facial pain.
Thank you. And for the person who shared, thank you for sharing that. And I hope that your pain is managed in your life.
Thank you. Here's another question. How common is the development of trigeminal neuralgia after damage to the lingual or inferior alveolar nerve during oral surgery, especially after the removal of wisdom teeth?
So as a matter of semantics, we would say that it's more commonly assumed to be what we call PTTN, or post-traumatic trigeminal neuralgia, that occurs after a traumatic injury. And you're correct, the person who asked the question, that the inferior alveolar nerve and the lingual nerve are often affected. Extractions and even dental implants can bring on this type of disorder and or dysfunction. And one of the problems is that it's very poorly understood in the dental community. So in terms of how common it is, I don't have a number for you, but Facial Pain Association maybe has that statistic. But it is something that we are working, those of us in interprofessional education circles are working to educate more providers, dentists and physicians, so that they think along those lines instead of immediately thinking that any facial pain is trigeminal neuralgia.
Thank you so much, Susie, for that. You know, as you mentioned, there's not a lot of research, I think, that exists on that. And we will be launching a patient registry through the Facial Pain Association in the coming year. And we do hope to gather information and data on the various forms of facial pain that people within our community have. So stay tuned for that. And if you do have patients that you you help in your dental practices that could benefit by participating in this registry, that's obviously something we would appreciate your support with. Here's another question. Have you found Botox or capsaicin topical beneficial for peripheral neuropathy?
Yes, I actually do. I like to use Botox for the right indications, and I have found Botox to be helpful. I kind of hear from my patients just empirically that it may work for them for a little while, but it isn't, it isn't going to be a long-term kind of type of relief for them. Capsaicin, I do know people who use it and get good results with it. I have not had that experience myself. Capsaicin has been a little hit and miss for me, but I do know that there are patients who say that it helps them quite a bit. I think we want to always start with first line medications like carbamazepine and gabapentin and those types of medications for trigeminal neuralgia. And then when we need to, we can go out and, into the other options that we have available to us. And what we want to do is try to keep from having breakthrough pain, because as long as we're able to manage, especially like Bennett mentioned, when it's a younger patient, the surgeries that are done for trigeminal neuralgia, like the microvascular decompressions, that you may get 10 or 15 years of relief. You may end up having to have a gamma knife surgery or something else down the road. So as long as we can manage the pain non-surgically, that's really a good goal for us.
I'd like to answer as well. I had Botox added to my treatment plan in late 2019, and I call it another one of the tools in my toolbox. So I find that all of these things together control my pain, and I am able to receive the treatment. The state of Missouri pays for this. I do not have migraines. I've never had headaches, but I am able to receive the 12-week dosage of injections of Botox.
Thank you so much, Anne-Marie. Thank you, Dr. Susie. I think we have time for one more question. Could an IA block, actually, there's two remaining questions really, and I'd like to get to both of them if we can. One is, could an IA block cause TN? And then the second question is, do you recommend avoiding any certain foods that may trigger TN? I think they're both important questions, and I really particularly like that last one.
So I have never read anything about an IA block causing TN, but I will be honest that I don't know the answer to that question. It doesn't seem to make sense to me from a anatomical point of view. If any of you on the panel know of that, please educate me. But most often TN is either caused by compression on the trigeminal nerve by a vessel, or it's caused by a disorder like multiple sclerosis or something of that nature that can cause some irritation to the trigeminal nerve at the base. So I would say no. And then the other question was foods to avoid.
Yes. So what do you think about, I'm sorry, that was a different question. Do you recommend avoiding certain foods that may trigger trigeminal pain?
I would say avoid anything that triggers your pain. So whether that be food or talking, well, I know you can't avoid talking entirely, but like Anne Marie said, she would have an air of thoughtfulness while she allowed the pain to disperse. If brushing your teeth, like Bennett mentioned, is painful, obviously we can't avoid brushing our teeth, but we want to try to minimize triggers as much as possible. So for instance, if you go outside and wind is a trigger for you, then you may have a way to cover your face without touching it to the point that it also triggers something. And that's what makes trigeminal neuralgia so horrible, is that a lot of the things that trigger the pain are things that we need in life, you know. So but if you have a food that triggers it, maybe replace that food with something else that you can enjoy pain without pain.
As
Thank you.
far as food, I think everybody's different, but it's very common to have bad reactions to ice and cold foods. So it's the extremes. So I know cold drinks or drinks with ice are a big trigger for me. So I don't have drinks with ice. It's very easy. So I think those are some triggers. Warm, soft foods are often comforting, things you don't have to chew very hard. Although sometimes, if you can stimulate the ninth cranial nerve, sometimes you can tamp down the fifth. Am I right about that? Is ninth taste?
Mhm.
So sometimes there's
Mhm.
nothing better for me than a nice hard sourdough pretzel. It's got lots of salt on it. So everybody's different, but I would say the cold foods are common triggers.
I just want to emphasize something that Anne just said very briefly, but also that one of my neurologists, I believe very deeply in having a polyamorous relationship with your neurologist, which is to say, have multiple neurologists. It's really important to having lots of different opinions. And I think part of the reason for that is because everyone's TN is different. One of my neurologists has said that like TN is actually just like the name of a box, and like lots of different things go in the box, and they're all kind of similar, but like they're not all the same. And so what might be an extraordinarily painful trigger for some people is not a trigger at all for other people. Wind is not a problem for me. Outside of the mouth touching, not a problem for me. Inside the mouth touching, excruciating. Everyone's different. And I think that like, it's good to say, you should try to see if this is a trigger for you, but to assume that something will or won't be a trigger and to construct a strategy accordingly of care for a patient is destined to fail.
Well said, Bennett, and thank you so much, Anne Marie, Bennett, and Dr. Susie for being with us this evening for the presentation. Again, the code for this evening's webinar is Bergman FPA Dental Ed. You can log into your CE Zoom account to take the quiz, and you'll find your course on your dashboard under scheduled courses. And again, you'll just take the quiz, click the button, enter the verification code after this presentation, take any mandatory tests. Your certificate will be in the records under Manage CE. Please allow 72 hours for us to confirm your attendance. And if you have any issues with the verification process, please reach out to support.cezoom.com. Thank you again, everyone, for joining us and being with us here this evening.
Thank you.
Thank you.
Thank you all.